Welcome to this edition of Milestones in Oncology, an educational program developed by the Society for Translational Oncology. The conventional treatment of breast cancer is undergoing a major change derived from the development of new targeted molecules that exploit differences in gene expression between malignant and normal cells. Since these pathways are essential for cell proliferation or metastasis, their perturbation often culminates in cell death through apoptosis. Furthermore, because these molecular targets are usually abundant in cancer cells, patients may expect to encounter fewer side effects. Targeted therapy and breast cancer is the topic that our interlocutor, Dr. Bruce Chabner, will discuss with Dr. Eric Weiner, a clinical investigator whose research has mightily improved the length and quality of life for breast cancer patients. I'll now leave it to you, gentlemen, to carry forward as I head to the control room. Thank you.
Thank you, Marty. We'll see you later on. Eric, this is a very interesting topic for us, targeted therapy in breast cancer. I guess the story really begins about 45 years ago when it was appreciated that the estrogen receptor was really a marker for responsiveness for hormonal therapy. And that probably was the first true biomarker and targeted directed therapy in cancer treatment. And we've come a long way since then. And one of the most important milestones in that journey has been the discovery of the HER2 receptor and its role in aggressive breast cancer. And I guess you were there at the inauguration of Herceptin as an effective agent. Maybe you could begin the story by telling us a bit about that.
Sure. Well, you know, the way we think about breast cancer today is very different from the way we thought about breast cancer 5 years ago, 10 years ago, 20 years ago when I really first started as a medical oncologist. You know, at that point in time, we thought of breast cancer as one disease. And when patients said to us, what kind of breast cancer do I have? We'd say you have stage 1 breast cancer, you have stage 2 breast cancer, but we wouldn't say you have HER2 positive breast cancer or you have ER positive breast cancer, although in truth, astute clinicians certainly knew that there were different subtypes of breast cancer.
Differently.
They just didn't have names for it. We didn't have the nomenclature. Yeah. So, you know, clearly there was a recognition that estrogen receptor positive breast cancer was somewhat different from estrogen receptor negative breast cancer, and we can come back to that, and that's an understanding that has evolved even more. But HER2, over the course of the past 10 to 15 years, has really turned out to be a hugely important marker. Initially, because it identified a group of tumors that had a more aggressive behavior. Women with HER2 positive breast cancer were more likely to present with more advanced disease, were more likely to develop recurrences. And then we learned, even before we had trastuzumab available, that women with HER2 positive breast cancer probably were more likely to get benefit from drugs like anthracyclines. But what really changed the landscape was having the availability of a targeted therapy. And the initial trials with trastuzumab began in the early to mid-1990s. Those initial trials, there were 2 of them, one with trastuzumab as a single agent and one with trastuzumab in combination with cisplatin, a drug that at the time wasn't used very commonly for breast cancer. Those 2 initial trials both suggested that there was some activity, although certainly the level of activity wasn't huge.
Yeah, so it was rather surprising that here we now have, you know, a major drug used almost continuously in patients with HER2 positivity and doing remarkable things with chemotherapy. So this is an incredibly important discovery. Now, we've moved a bit past that recently with the discovery that a small molecule can do much the same as Herceptin. Let's just review where we stand with Herceptin before we move into the discussion of lapatinib.
Sure. Well, you know, with Herceptin or trastuzumab, I think that to some extent today many of us are surprised to what extent it actually has changed breast cancer treatment. Remember when the randomized study, the study that Dennis Slayman ultimately published in the New England Journal of Medicine, when that study was initially started, our view of breast cancer was so very different that at that point in time, the war cry was high-dose chemotherapy and bone marrow transplant. This is the mid-1990s, and the interest was in pushing dose and giving more and actually making people much sicker and taking them to death, actually, unfortunately, in some cases, to death. Yeah. And it's hard for us to imagine, but the initial randomized trial with Herceptin could easily have failed if for no other reason other than the fact that doctors just weren't that interested in it. And people like Dennis Slayman actually had to go around and rally people to get them interested. So that initial study that was conducted in roughly 450 patients, comparing chemotherapy versus chemotherapy plus trastuzumab, demonstrated an improvement in response, an improvement in time to progression, and very importantly, an improvement in overall survival. And that improvement in overall survival was seen in spite of the fact that about 2/3 of the women who were randomized to receive chemotherapy alone ultimately went on and were crossed over to receive trastuzumab after they developed disease progression. And what has really evolved from that is a new standard of care. And of course, for women with HER2-positive metastatic breast cancer, first-line therapy when one is beginning chemotherapy always includes trastuzumab. There is absolutely no rationale to begin with chemotherapy alone for a woman with HER2-positive metastatic breast cancer. And of course, we've moved beyond that initial study with Slayman, from Slayman, such that we now have multiple different treatment regimens, multiple different chemotherapy agents that can be given with trastuzumab. And my general sense is that it almost doesn't matter what chemotherapy you give with trastuzumab. You need to sprinkle a little chemotherapy in with the trastuzumab, but that a little therapy, a little chemotherapy added to trastuzumab results in most cases, it would seem a much more substantial benefit than with trastuzumab alone.
So it seems to be setting cells up for the kill, and that's an interesting concept. It's sensitizing to apoptosis. We understand a little more about that, the pathways involved. It probably involves the PI3 kinase pathway and deactivating that, which leads to greater sensitivity to apoptosis. There are some problems with Herceptin, and some of them are unexpected. One is the cardiac toxicity with anthracyclines, and that's dampened some of the enthusiasm for combination therapy with anthracyclines, which are considered among the most active drugs. The second problem is this interesting issue of late relapses in the CNS. And I think you've been instrumental in your group in identifying that and trying to approach it in different ways with new therapies. So maybe it would be useful to review a couple of those significant new disadvantages or toxicities or outcomes that we face with the use of Herceptin.
Well, there's a lot to be talked about in terms of anthracyclines and Herceptin, and in truth, it's still an evolving story. Initially, with that randomized trial from Dennis Slayman, there was an increased risk of cardiac toxicity giving adriamycin in combination with Herceptin, and as a result of that, it is certainly not considered a standard treatment. Interestingly, both some investigators in Germany and Aman Buzdar at MD Anderson have actually recently looked at epirubicin with Herceptin. And while I personally don't think that it's a combination that I would use outside of a trial, they've reported very, very high response rates, particularly from the MD Anderson study in the preoperative setting, and have indicated that from a cardiac safety standpoint it's been tolerable. I would not do that outside of a trial.
Yes.
But I think that the final chapter in terms of anthracyclines and Herceptin has not been written, and we'll have to see how it all plays out. Now, at the same time, of course, there are many who believe that when you give drugs like Herceptin, you may not need anthracyclines anymore, so that perhaps they can just be eliminated in some, many, maybe all patients, and that also is something that we have to learn more about.
It's possible to replace them, for example, with taxanes.
That may well be the case. In the BCIRG study that compared the TCH regimen, taxotere carboplatin Herceptin, with ACTH, AC and taxotere Herceptin, suggested in the adjuvant setting that the two regimens had equivalent outcomes.
Yeah.
Now, the story with brain metastases is one that is both a success and a failure. And it's a success in the sense that we learned about this because Herceptin was working well.
Right. And patients were living longer.
Patients were living longer, and patients were not only living longer, they were living better. And it was around 2000, 2001 that many of us started to observe that a high proportion of women who were receiving trastuzumab-based regimens in the metastatic setting were developing progression in the CNS. And oftentimes, this was occurring when a woman was doing well from the standpoint of her extra CNS disease. Our group reviewed records at Mass General and at Dana-Farber and at the Brigham, and this was now in between 1998 and 2000. And what we identified through a review of pharmacy records is that about a third of patients who were treated with trastuzumab-based regimens were developing disease progression in the CNS. About half of them were developing that disease progression when their other disease was under control.
Yeah, so it's only in that side. You know.
And about half of them, those that developed this progression, really seem to have that become the major force. You know, so that a small proportion of them, in fact, went on to develop progressive disease in the CNS and die a death that I think
without systemic disease.
The kind of deaths that people with primary brain tumors succumb from.
So there are a couple of other possible explanations which are important in thinking where we go next. One is that HER2 disease has a predilection for the CNS, and we don't really understand the different biology of Herceptin well enough to know if receptors are expressed that allow cells to locate there. The second possibility is that as an antibody, a monoclonal antibody, it doesn't penetrate well into the CNS. And so an alternative drug might do better. A small molecule traditionally has been more effective than monoclonal antibodies in treating CNS disease of various kinds. So, for example, lymphomas. So that raises the issue of could a different approach to HER2 therapy lead to better CNS control. So now we have, in about 5 years ago, the entrance on the stage of lapatinib. Tell us a little bit about lapatinib and how it's different than Herceptin.
Sure. Well, lapatinib, unlike Herceptin, isn't a monoclonal antibody. It's a small molecule tyrosine kinase inhibitor. It inhibits HER1, or the epidermal growth factor receptor, and HER2. I think many of us believe that it is a much more potent HER2 inhibitor than a HER1 inhibitor, at least partially as a result of the fact that the toxicity with lapatinib is really somewhat different than with the EGFR inhibitors, somewhat less in the way of cutaneous toxicity than you see with drugs like Tarceva or Iressa.
Is there much diarrhea with the drug?
There is some diarrhea. My impression is that it may actually be a little less than with the EGFR inhibitors, but it is one of the side effects one has to watch for, and it's dose dependent, and of course, particularly as we'll get to when you think about giving it with
now breast cancers do express EGFR receptor, right?
They do,
and it's not mutated. But
and in particular, it's recently been reported that the so-called triple negative, often called basal-like breast cancers, not that the two terms are entirely synonymous, but that those cancers, about half of the time, overexpress EGFR. But what is not at all clear is that the EGFR inhibitors are particularly valuable from a therapeutic standpoint. We did a study with Tarceva in breast cancer, not selected based on EGFR expression, that was essentially negative, meaning entirely inactive.
Yeah.
There is a similar study that was done with Iressa.
How about Erbitux? Has that ever been studied?
So Erbitux was looked at, to my recollection, in one study. More recently, though, Lisa Carey at the University of North Carolina at Chapel Hill working with a group called the Translational Breast Cancer Research Consortium, which we may want to come back to, has done a study looking at single-agent cetuximab in women with triple-negative breast cancer, and that actually is going to be reported at San Antonio this year.
Any hints about what they're going to find?
Probably not at liberty to say much, but
Okay. It's an interesting study.
it's an interesting study.
Yeah.
There probably is not as a single agent, probably not a tremendous amount of activity.
There is also a lesson that we've learned with other targeted drugs, that you can't always judge the impact of the drug by looking for clinical responses. You may have to put it in a combination. You may have to look at time to progression to really see the effect. So maybe we shouldn't give up on the idea.
I don't think we should give up. And in fact, in that study that Lisa Carey ran, it was a randomized phase 2, and in the group we looked at cetuximab alone. We also looked at the combination of cetuximab and carboplatin.
Yeah.
And it is certainly conceivable that a drug like cetuximab, even if it weren't effective on its own, might augment the effectiveness. Now, that said, with the HER1 small molecule inhibitors, when those agents, again, Iressa, Tarceva, have been combined with either hormonal therapy or chemotherapy, the results have not been impressive.
Dismal. Right.
And in fact, one of those agents, Iressa, was combined with Herceptin in a study, and there too there seemed to be no added value other than toxicity, of course, no value.
So we return to the idea that probably lapatinib is mainly exerting its activity through the HER2 receptor. And yet it has some unique effects in breast cancer. It's not exactly the same as Herceptin. So tell us about some of the interesting things you've seen in the trials.
Well, so why don't we talk about brain metastases first? And you know, as you mentioned before, in HER2-positive breast cancer, there seems to be this increased risk of brain metastases that's probably coming for a number of different reasons. HER2-positive breast cancer, long before there was Herceptin, was a subtype of breast cancer that was known to have a predilection for the CNS. So this is a group of patients where CNS metastases are more common. Second, women are living longer as a result of treatment with Herceptin. And third, and perhaps most importantly, I think the strong sense is that Herceptin just isn't penetrating the CNS, which is why it is suppressing cancer growth below the neck and not above the neck. And with all of that in mind, and actually in response to the fact that we had a patient population that was coming in with progressive CNS disease, our group now, several years ago, wrote a grant, one of the Avon Partners for Progress grants through the NCI, to look at lapatinib in patients with CNS metastases. And we did an initial study that we worked on with Mass General and with the Beth Israel in Boston and the University of North Carolina at Chapel Hill in Georgetown. And we looked at lapatinib in a group of women who had previously had Herceptin and who had progressive CNS disease. So all of these women had already had a HER2 inhibitor, and all of them except 2 had actually previously had radiation to their CNS. The vast majority had had whole brain or whole brain plus stereotactic radiosurgery. A very small number had had stereotactic radiosurgery alone.
And they all had progressive disease.
And they all, upon coming into the study, all of these women had documented progression. And what we observed in that study, and I should mention that my colleague Nancy Lin is responsible for really all of this work.
Yes.
She did a beautiful job with this study. And what was observed was that while there were very few objective responses as measured by RECIST, and the manuscript is now in press, and in fact of the 39 patients, there was one objective response by RECIST, a partial response, a response that was actually quite durable. But there was the suggestion of some amount of activity beyond that. And that suggestion came from an assessment of volumetric changes. So although we had trouble documenting that lesions shrunk sufficiently to meet criteria by RECIST.
Yeah.
There were declines in volumetric measurements. And
the so-called waterfall plots.
Yes.
Yeah.
And a proportion of patients, about 20% of patients, had reasonably prolonged periods of time of disease stabilization.
Yeah.
You know, somewhere in the range of 4 months or longer. And given the fact that these patients were all coming to the study with disease progression, we actually thought that that was of interest.
Yes.
And based on that study, in fact, GlaxoSmithKline went ahead and ran their own large multi-center phase 2 trial that involved approximately 240 patients looking at lapatinib in patients with progressive CNS disease. That study was also reported by Nancy Lin at the American Society of Clinical Oncology this past year, and suggested that in this multi-center study, if anything, there seemed to be a little bit more activity than we had observed in our study, with an objective response rate now based on volumetric criteria that was in the range of about 5 to 10%.
So it probably is getting in better. It has some extra activity that you see with these minor responses in stable disease. But I guess the real benefit would be in an adjuvant setting or in people who don't have CNS disease. If you start the drug before they get it, can you prevent them from having that? So what's happened now?
Yeah. So in our mind, this was a signal that there was at least some activity, that the drug was getting in, at least to some extent. And of course, it may not be getting into the brain as well as it's getting to other places. And so efforts to try to enhance drug delivery to the brain for patients with CNS tumors, both primary tumors and metastatic tumors, remain very, very important. But so our sense was that it was getting into the brain and that it had some amount of activity. And so in thinking about it, our view is that one possibility is, of course, taking it earlier on, and it's being looked at in the adjuvant setting. The other, of course, is to look at it in combination with other CNS active treatments.
Right.
Because, of course, we know that when lapatinib is given as a single agent to a woman who's previously had Herceptin and has developed disease progression, that as a single agent, it too works 5 to 10% of the time in the lymph nodes, in the lung, in the liver.
By itself.
By itself. So what we were seeing in the brain isn't very different from what was seen with lapatinib alone elsewhere.
Right.
And yet, lapatinib combined with drugs like capecitabine, of course, seem to have a much greater degree of activity. It's something that I've said for a long time, and others would agree with, although maybe not all others, is that my very strong impression is that when women with HER2-positive disease develop disease progression on Herceptin, that progression looks and feels very different than did the initial presentation. So HER2-positive breast cancer often presents with sort of an explosive presentation. Women present with bulky liver metastases, a great deal of symptoms. When they develop disease progression after that first course of therapy, not always, but very frequently, the disease progression is much more indolent,
subtle,
suggesting that there's another pathway that's been identified and that the cancer just can't quite go down a big open highway.
You're still suppressing the really aggressive behavior that was there in the beginning.
That may well be the case. And
so what did we find with the subsequent studies in these progressors with lapatinib in combination?
Well, there is one very well done study that we can talk about, and that is the study that Chuck Geyer and David Cameron have presented and published. It was a trial that looked at capecitabine versus capecitabine plus lapatinib in a group of several hundred women who had received prior anthracycline, taxane, and trastuzumab. And in fact, virtually all of the women had developed progression on the trastuzumab-containing regimen. And in that trial, the combination arm, that is, women who received both lapatinib and capecitabine, had a higher response rate, but most impressively, had a very substantial increase in the time to progression. Almost a doubling in the time to progression.
So suggesting that you're affecting a lot more people than just those that are showing partial response.
And it wasn't that the group of women who received capecitabine alone did so poorly. In fact, they did every bit as well as one would expect from a group of patients in this setting who were receiving capecitabine. Now, the other interesting finding, and this did not meet criteria for statistical significance, but there was the suggestion that there were fewer patients who developed disease progression in the brain among those women treated with capecitabine and lapatinib compared to those who received capecitabine. And that might suggest a couple of things. One, that the use of an agent like lapatinib to address the brain metastases problem might be more effective if given somewhat earlier. And second, it may say something about the value of the combination, because capecitabine is actually a chemotherapy agent that people think gets into the brain.
So here we have a drug which is active in patients, or at least it's active in combination with patients who progressed on Herceptin, seems to enhance chemotherapy significantly, lower CNS recurrence rate. So it looks sort of promising to move it up. So what's the next step for this drug? How do you move it up?
Well, outside of a trial at the moment, I think where it belongs now is after trastuzumab. But it is being evaluated in multiple trials. And in the metastatic setting, it is being evaluated in combination with chemotherapy compared to chemotherapy alone in trials outside of the U.S., in countries where trastuzumab is not available. Not a study you could remotely do in the United States, because trastuzumab is the standard of care.
So a positive result there would suggest that it might actually replace Herceptin, although you'd have to do the trial to verify that.
You would. A positive result there would at least provide some reassurance that it could substitute, at least to some extent, for Herceptin.
So, Eric, let's take a closer look at some of the trials that are going on that may change the way we use lapatinib. Tell us about some of these interesting studies.
Sure. Well, lapatinib is being looked at in a number of different settings, in the metastatic setting, in the preoperative setting, and in the adjuvant setting. So why don't we start with the metastatic setting? There are several large trials. Outside of the U.S., there is a trial that is ongoing looking at paclitaxel plus lapatinib versus paclitaxel. This is not a trial that could be done in the United States because, of course, Herceptin is the standard. But it's a trial really to give a sense in a group of patients who have not previously had Herceptin just how much lapatinib will add to standard chemotherapy, in this case paclitaxel. There is another trial looking at the combination of lapatinib and Herceptin in combination with a taxane compared to just the standard taxane Herceptin, seeing if, in fact, by adding another HER2 inhibitor on top of the standard therapy, whether you can improve outcomes, response times to progression, survival.
Will one of the endpoints in that trial be CNS metastasis?
It will be, and I think that across the board in all of these studies, there's going to be a great deal of interest in looking at the proportion of patients who develop CNS disease. In the preoperative setting, there are a whole range of different regimens being looked at. The CALGB is getting ready to launch a study that will compare paclitaxel trastuzumab versus paclitaxel lapatinib versus paclitaxel lapatinib and trastuzumab. All preoperatively, women receive 16 weeks of the therapy, and then we assess pathologic complete response at the time of surgery. And of course, one of the advantages in terms of therapy in the preoperative setting is not only do we get an immediate assessment in terms of the degree of benefit, but we have access to tissue, so that in patients who have a great response, we can try to interrogate the tissue to look for predictors of that. And for those patients who have residual disease, we can try to understand about resistance. And this, in my view, is really critical. It's actually a different approach than we've taken in the CLGB before, and both this study and another trial we have in the triple negative setting are very, very important to us. But perhaps most importantly, there is the gigantic adjuvant trial that is now launched in Europe and will be launched in the United States within a matter of weeks. That trial is being co-led by Martine Picard from the Breast International
Right.
Group and Edith Perez from the U.S. Intergroup and the North Central Group. And that trial has 4 different treatment arms. All women receive chemotherapy, and as is typical of many European studies, there's some choice in terms of chemotherapy.
Yes.
It's not rigidly
So it
prescribed.
could be epi or
It could be epi. It could be
doxy or
right. So actually, you can
with or without Taxol.
with or without a taxane is the key.
Yeah.
Now, the 4 treatments that are being compared are trastuzumab alone for a year, lapatinib alone for a year, the combination of lapatinib and trastuzumab for a year, and finally, trastuzumab for several months, followed by lapatinib for the remainder of the year. And on that study, if a woman receives a taxane, the HER2-directed therapy begins with the taxane. If she just receives an anthracycline, as will be the case in some of the European countries, the HER2-directed therapy starts afterwards.
Afterward, because of the cardiac issues.
The study will include 8,000 patients.
Wow.
It will enroll patients over the course of probably 2 to 3 years is the projection. And hopefully 5 years from now, we will have an answer as to what role lapatinib can play, either in addition to trastuzumab or potentially even in place of it in the adjuvant setting.
Is there any effort to simplify the chemotherapy that's given with Herceptin or with lapatinib?
Yeah, so this is a great question and an area that that I'm certainly interested in.
Yeah.
Partially relating to my comment before, which is that when you give these targeted therapies, maybe the chemotherapy doesn't matter as much. I mean, it matters to give chemotherapy, but maybe the exact chemotherapy matters less, and we could get away with somewhat less toxic therapy. So the one setting in which we're looking at this is that in the group of women who have node-negative, HER2-positive breast cancer with small tumors, a group of women where we really don't know what to do, women who have a ER-positive 1.2 centimeter node-negative HER2-positive cancer.
Do they need the full
Do they need the full
gun?
flog? And I think many of us are really not anxious to give those women AC followed by TH or TCH even. And so we have a multi-center trial that has just started looking at paclitaxel and trastuzumab for 12 weeks, followed by the completion of a year of trastuzumab in just this patient population. And it's a phase 2 trial. There are not 2 arms.
There's no second arm to this.
And that's a weakness, but the problem is we didn't think we could enroll in a randomized trial. And rather than have treatment that is just all over the map in patients, we thought that we would give a uniform treatment course and describe treatment outcomes in these patients. And in truth, if that proves to be successful in this group of lower risk patients, I could imagine that people might be more comfortable looking at it in a somewhat higher risk group of patients.
Well, let's go back to the issue of cardiac toxicity. So how much evidence is there now that lapatinib doesn't have cardiac toxicity?
Well, most of the evidence comes from studies that have included women who have previously had Herceptin and who, in entering those studies, had a normal ejection fraction. So
they've survived Herceptin.
They've survived Herceptin.
They may be a tougher group than the ones
and
that up front developed cardiac toxicity.
Right, and not all the evidence is from those women, and there are women who have not previously received lapatinib. For that matter, lapatinib has been used in the setting of other malignancies where anthracyclines and treatments like trastuzumab aren't used.
Yeah, you'd have to say, though, that that's probably, that's one possible explanation for the lack of cardiac toxicity. But with other drugs, for example, with mitoxantrone following anthracyclines, you certainly saw significant cardiac toxicity after following a cardiotoxic drug. So I'm not sure that we can explain it that way. Have there any, in some of these new studies where the patients haven't seen Herceptin in the past, lapatinib is now being used? We'll get a better idea, I think, maybe.
I think we will, and
how much to expect. in cardiac toxicity.
We will, and it is reassuring that even in these women who have previously received trastuzumab, many of whom have previously received an anthracycline, that we're not seeing much in the way of cardiac toxicity with lapatinib. The few cases that have been reported in these studies have suggested that this may be less of a problem than with Herceptin, but I think that the final word isn't out, and I wouldn't be comfortable with a definitive conclusion that lapatinib is clearly less cardiac toxicity. It remains to be seen, and it is importantly one of the questions that will be addressed in the adjuvant studies.
So let me ask you a practical question. You, as a physician, you're faced with a woman whose ejection fraction is on the border of being abnormal and yet has positive nodes, and you want to give her a drug that is going to inhibit HER2. Would you consider at this point using lapatinib in place of Herceptin, or how do you handle that situation?
So in the adjuvant setting, it would make me pretty nervous to replace trastuzumab with any other drug. And I don't know that in a woman whose cardiac function was so low that I didn't want to use trastuzumab that I would use another HER2-directed agent like lapatinib. In the metastatic setting, I become a little bit more comfortable both because I can look to see if she is responding to therapy, and perhaps because I'm a little less worried about cardiac toxicity.
The eventual
in that
outcome
setting.
is pretty well established.
On the other hand, of course, in the metastatic setting, I do know the eventual outcome, and in the adjuvant setting, I'm of course trying to cure a patient, so I'm very worried about giving that woman the best therapy. But in the metastatic setting, I think that substituting lapatinib, if there were a strong reason not to use trastuzumab, is something that one could consider. But in truth, if a woman's ejection fraction were in the 40 to 50% range,
that's not bad enough.
I might think about using Herceptin and watching her closely.
Very closely,
If it were very low, I'd be pretty anxious about using lapatinib, and so I think we're talking about a small group of patients.
How reversible is the cardiac toxicity of Herceptin?
In the adjuvant setting, where I think we have the best data, we know the following. So one, we know that the anthracycline-containing regimens, those that used anthracycline followed by trastuzumab, seem to produce more cardiac toxicity than regimens like TCH. Second, we know that across all of the studies, the incidence of cardiac toxicity ranges from about 0.5% to as high as 4% in the NSABP study. Third, we know that generally speaking, the cardiac toxicity is seen relatively early, meaning during treatment, and doesn't seem to evolve in the few years afterwards, although, to be clear, we don't have 5 and 10 and 15-year follow-up data. The predictors, at least in the hands of the NSABP, are age, history of antihypertensive medications, and a borderline EF. And finally, there is the suggestion that there has been recovery, but what we don't know is how many of the patients who have recovered have still needed to be on medication for congestive heart failure. And it's one thing to say that a woman isn't suffering from congestive heart failure because her ejection fraction is higher. It's another to say that it's all better and never a problem again.
It's real fully recovered.
And I don't think we know that yet.
So, Eric, is left chest irradiation a predisposing risk factor for cardiac toxicity with Herceptin?
So generally, the feeling is probably not. In the studies, it has not shown up as an important factor to date. And importantly, our colleagues in radiation oncology generally do their very best to keep the heart out of the field. It's also important to remember that the cardiac toxicity with trastuzumab is congestive heart failure. With radiation, what we're really worried about is atherosclerosis and the long-term cardiac issues. But it's still an important issue, and I think it's something that we have to continue to pay attention to
at this point. So we have 2 drugs now, targeted drugs that attack the HER2 receptor, one of which may also have some activity against EGFR, and we're not sure whether that plays a role, but probably not. How do we deal with resistance to these drugs. We're not curing people with metastatic disease. We're getting benefit in adjuvant therapy, but we need to go further. What are the next steps, do you think, in targeted therapy for breast cancer?
Yeah, so we absolutely need to go further. And we know from the adjuvant trastuzumab studies that 50% of recurrences were prevented, but 50% of recurrences weren't prevented. There are still roughly 15% of women, if you take the patient population from the NSABP and intergroup studies, but 15% of those women 4 years out have recurrent disease, even with receiving a year of Herceptin. And I think it probably goes without saying that I don't believe that tweaking the chemotherapy is going to be the answer.
Yeah.
So we need to do better. I think first we need to understand resistance. And in spite of the fact that trastuzumab has been available now for 8 or 9 years, we're really just beginning to get some initial clues about resistance mechanisms. And in terms of resistance mechanisms to lapatinib, we're even earlier in the search. There are some clues, and there are a number of promising agents that are being looked at. Pertuzumab, which is an agent that has been looked at in phase 2 clinical trials and is now entering phase 3 trials in Europe, is an agent that inhibits binding of HER2 with HER3 or HER1, and is of interest, and as a single agent appears to have some activity. There's a great deal of interest in PI3 kinase, and agents that inhibit PI3 kinase are just beginning to enter the clinic in phase 1 trials, but PI3 kinase is thought to be very, very important both in HER2-positive breast cancer and in other subtypes of breast cancer. And there's a tremendous amount of interest in looking at these agents in patients with HER2-positive disease that is resistant to trastuzumab and or lapatinib. I think the future is actually pretty bright, but we gotta move. We got
to get out of the mindset that another chemotherapy drug is going to make all the difference. So one of the more interesting new targeted drugs is Avastin in breast cancer. Is that going to make a difference?
Well, there are reasons to think that it might, and here I assume you're talking about HER2-positive breast cancer still.
Yes.
Avastin in HER2-negative breast cancer in the ECOG 2100 study, clearly showed that there was benefit in terms of time to progression when added to paclitaxel. But there were virtually no patients in that study with HER2-positive disease. Our experience with Avastin in patients with HER2-positive disease is actually quite limited. There is a single study looking at the two antibodies, that is Avastin or bevacizumab and trastuzumab, given together, that was done by the UCLA group. They reported results at San Antonio last year, and they reported a response rate that was higher than had been seen with trastuzumab alone, a response rate that was in the 40 to 50% range. Some concern about cardiac toxicity raised by that study, not so much that it has limited development, and my understanding is that the BCIRG and the NSABP are moving forward with plans for an adjuvant study looking at the combination. But I think it remains to be seen, and I think all of us have struggled where, if ever, outside of a trial, to consider Avastin in the treatment of a patient with HER2-positive disease. And the truth is that I think that, for the most part, most physicians haven't done it yet.
There's another class of drugs which has really attracted some attention, and that's the HSP90 inhibitors. And they do something very interesting. They downregulate the expression of HER2 in HER2-positive tumors. So there's some early trials going on of Herceptin with the galdanomycin derivatives.
Absolutely. So, so this is work that's largely come from Memorial Sloan Kettering, from Shanu Modi and Cliff Hudis, where they've done a phase 1 and now a phase 2 trial looking at 17-AAG in combination with Herceptin. We don't know that continuing the Herceptin is important. They partially did it because they assumed that most women would be on Herceptin, and since it hangs around for a while, they didn't want the added variable of levels fluctuating. And they also presumed that it might not, the 17-AAG might not totally wipe out the receptor, and that it might still be important to have Herceptin.
To maintain the block. So the results of that trial, the early results were reported in San Antonio, and I understand that there was something like a 25% response rate in people who had progressed on other Herceptin regimens, which is interesting because this is not a cytotoxic drug. It's a totally different approach. And I'm sure there'll be other ways. I mean, we have a whole series of new drugs. There are inhibitors of BCL2 pathways, which promote apoptosis, these inhibitors, and other drugs, epigenetic modification of tumors, methylation inhibitors, which could really make a difference. So I think you're right. The direction of research and probably of clinical practice 10 years from now will be an entirely different spectrum of agents than we've gotten used to in the past. Do you think we're ever going to throw away the chemotherapy drugs?
Oh, I don't think we're going to throw away the chemotherapy drugs anytime soon, but I think that we will make them kinder and gentler, and I think eventually we may well. I've actually predicted publicly, so I guess I'm doing this again now, that 10 years from now, actually I said this a year and a half ago, so it has to be 8.5 years from now, we will have all the tools we need to be able to cure women or certainly prevent death from HER2-positive breast cancer.
Yeah.
I very much hope that's the case. I think it's a very reasonable goal to work for. One thing just to keep in mind is that in order to do that, we also, both within the U.S. and outside of the U.S., have to work on access to care, because we certainly can't help women who can't get into the medical system.
Yeah, or can't afford it.
And it's a problem we all have to deal with. I want to just raise one other issue, which is that I think here, in terms of understanding resistance to the available HER2-directed therapies, to a large extent, tissue is the issue. And we do need to design studies and proceed forward with studies where we can get access to tissue and we can understand what is going on in tumors. We can interrogate tumors to understand what's going on when these drugs are no longer working, because understanding the molecular changes ultimately can be fed back to the laboratory and to drug developers.
And so we really return to your original comments, which is breast cancer is not one disease, it's multiple diseases. And even within the subsets of disease, like HER2-positive disease, every tumor is going to have its own pattern, and there are going to be multiple ways in which tumors become resistant. So selection of therapy is going to be based in the future. I think there's no doubt about this. It will be based on understanding the profile, the molecular profile of the tumor. And it's going to be a much different way of approaching patients. It's not simply, you got breast cancer, here's the regimen, and see you in 3 weeks. So Eric, has been a very interesting discussion. Thank you so much for
having me.
The Society is proud to host this milestone in oncology, and we are especially grateful to Dr. Weiner and Dr. Chabner for their enlightening discussion that proffers new hope for breast cancer patients. We are also thankful to our benefactors for their unrestricted grant support, and to the peer-reviewed journal, The Oncologist, in whose association these programs are produced. Thank you.